first picture. This is X-ray of the paranasal sinuses. No, I will remind for you. Normally, what can we see? We can see orbit. This is to orbit. We can see maxillary sinus. Oh, sorry, nasal cavity. Maxillary sinuses, both sides. Frontal sinuses, both sides. No, partially ethmoidal cells, but not clear. And here, we must compare color of the sinuses with orbit. And here, what clearly we can see bony tumor in the frontal sinus. This is osteoma of frontal sinus. I remember this patient. It was young boy. He wanted to be admitted to the military university. No, in Russia, it's obligatory to do medical examination, and this examination includes X-ray of the paranasal sinuses. This patient had no problems, but on X-ray, what it's in this bony tumor, osteoma. Here you can see big tumor, which orbit, nasal cavity, maxillary sinus. Now, this is big tumor. After that, several CT. No, CT, when we do CT, on CT we have too many pictures in many projections. We cannot here show all of them, more interesting. Oh, this is one patient. X-ray CT of paranasal sinuses, frontal view. White color, this is bone. Black color, this is eye. Gray color, this is soft tissues, and fluid. No, here soft tissue. What you can see, this is orbit, nasal cavity, nasal septum. No, here it's deviated. Inferior turbinates, middle turbinates. And what can we see here? We can see total obstruction of the maxillary sinus by something. We don't know what is this, only histologically possible to say, but we can see this is aggressive mass because what you can see superior wall of maxillary sinus, which is inferior wall of the orbit, is broken, and this mass spread into the orbit. No, and this patient had exophthalmos. It's symptoms in the eyes. Other patient. This is CT in the horizontal view. What you can see, this is orbits, and what here you can see tumor. It affects the what between the orbit is ethmoidal cells, nasal cavity, and even spread on the face under the skin. You can see it, and another level here we can see also it affects the frontal sinus. Well, this is malignant tumor. It has so big size and affects so many parts. Paranasal sinuses, orbits, nasal cavity. Here we can see CT of paranasal sinuses, CT of the skull, possible to say, in the frontal view, and here you can see posterior part of nasal cavity. This is choana, communication of nasal cavity with nasopharynx. What inferior turbinate, middle turbinate, and superiorly we can see what very big bony tumor, osteoma. This is osteoma of sphenoidal sinus. Also, I remember this patient. It was patient in our department. We removed this osteoma through the nose, but it was very, very difficult because it's osteoma, it's bony, and it's big, and it don't pass through the small opening of the sphenoidal sinus. And it was necessary to do fragmentation of this tumor inside the sphenoidal sinus. It was finally this operation was successful. And about tumors of the nasopharynx. I repeat, I told already today, it's impossible to discuss all tumors because all of them different, and in all ENT organs, different tumors can develop. We will talk about more popular and more specific tumors of the ENT organs. What nasopharynx, one of more typical tumors of nasopharynx. This is angiofibroma of nasopharynx. This is fibroma and angiofibroma, because it has relation with vascular tissue, it has very good vascularization. The etiology. No, what about etiology? I didn't talk at the beginning. Etiology, like all other tumors of the etiology, is unknown um, completely. Yeah, we have many factors, many factors. It can be pollutions of environment, it can be radiations, tumors of respiratory tract, smoking, it can be family anamnesis. But exactly we cannot say etiology of all tumors. Sometimes people from one side, from first appearance patient had no some etiological factors, but tumor present. This tumor, this is benign tumor. The fibroma of nasopharynx, benign tumor, histologically benign, but clinically it's like malignant because it can grow quickly, and during growing it can spread in other organs and neighbor organs. But no, because it's benign, it spread not due to growing inside the tissue, and spread due to mechanical enlargement and pressure on the neighbor organs. No, and because it's benign, it don't give metastasis. It's typical for young men, not possible to say for boys, age before 20 and even less, but it's more typical. Also, it can present in other age, and also it can present in female, also can present. Because this tumor localized in nasopharynx, it's first of all, we must differentiate this tumor with adenoid hyperplasia. No, and age also, no, possible to say typical young. No, adenoid hyperplasia typical for more young, for children, but in this age also it can present. And angiofibroma also can present in children. In this case, first of all, we must differentiate with adenoid hyperplasia. And adenoid hyperplasia we discussed 2 lectures before. And first of all symptoms which present in adenoid hyperplasia also present in this tumor, because this tumor mechanically block the nasopharynx. And because what mechanical blockage of nasopharynx, symptoms like adenoid hyperplasia. No, this is nasal obstruction, development of sinusitis, different types of sinusitis. It can be snoring at night. It can be affection of the ear due to blockage of the eustachian tubes. It can be different problems in the ear. It can be rhinolalia clausa. It can be headache. No, middle ear, I talked already, different diseases, middle ear catarrh or purulent diseases of the middle ear. And, but additionally, because this is angiofibroma, because it has very good vascularization and it has relation with vascular tissue, what it can be nasal bleeding. Periodically, no, usually nasal, maybe from the mouth also bleeding. No, more typical situation, bleeding for the nose. In examination, how can we see it? No, we discussed in details on previous lecture how can we examine nasopharynx, all organs about which we talked. Значит, nasopharynx, how can we examine? We can do posterior rhinoscopy, anterior rhinoscopy, or endoscopic examination. First, we do it by hand, manual examination. Additionally, we can do X-ray, CT. First, about primary examination. Visually, we can see mass in nasopharynx, which block the nasopharynx. Usually, it has smooth surface. Usually, it has color, can be grayish color or pink color. And what here, for example, it's very clearly seen vascularization. Very good vascularization of this tissue. During palpation, if we do palpation, we can touch this tumor during examination, for example, by some instruments. It's very hard. It's hard, but usually, sometimes it can be soft, but usually hard. But we must remember this tumor is very dangerous. It's very dangerous to walk with dangerous situation can be developed if we walk this tumor. If we palpate it, if we touch it, we can get serious bleeding. In this cause, what we must be careful. And if we see patient with this tumor, always we must be ready for bleeding. We must prepare everything to stop the bleeding. Also, we will talk more detail about treatment. Also prepare blood or some special components for transfusions, especially if we talk about surgical removal. And in this cause, what serious problem here? What about biopsy? How to do biopsy? Because what biopsy also have a very serious risk of complications, serious risk of bleeding. Examination. What examination should we do in this situation? Now 21st century and more effective examination is CT. If we have possibility to do CT, it's necessary to do CT. No need to do other. Other examination also possible to do. I will talk after several minutes. I mean, no need to do X-ray, ultrasound, MRI, CT. CT is more effective, and CT will show for us this tumor. Why CT is important? Because I talked already. This tumor can spread to the other organs. It can spread to nasal cavity, to paranasal sinuses, and even to cranial cavity. And if it spread to the cranial cavity, it can lead to the development of intracranial symptoms. First of all, usually this is problems with third, fourth, and sixth nerves, cranial nerves, because this area affected more often. All these nerves responsible for movement of the eyes, and it will be symptoms of problem with movement of the eyes. Other symptoms also can develop. It's already if diagnosis was not put in earlier stages, and tumor will be very big. And CT allow for us to see size of this tumor and spreading of this tumor, because in visual examination, even if we do endoscopic examination, we can do only external part of this tumor, and we don't know how deep it's localized, how deep it's spread. In this situation, we do CT. For example, I look at this picture. This is CT. This is this tumor schematically. Origin here, nasopharynx, but it can spread to the oropharynx, that I didn't say, and even can lead to the problem with swallowing of nasal cavity. Here endoscopically we can see this tumor. On CT, here you can see CT of paranasal sinuses in horizontal view. You can see this tumor. It's present in nasopharynx, spread to nasal cavity, spread to the maxillary sinus, spread to the ethmoidal cells. But what you can see border very clearly, we can see bony wall of the orbit. It's pressed on this wall, but this wall is not affected. And treatment. Treatment is clear. The treatment is surgical, but I talked already. This is vascular tumor. This has very good vascularization, and in all manipulation of this tumor, especially in the attempts of removal, we have very high risk of bleeding, and we must be ready for severe bleeding. And here two opinions present how to do it. One opinion, doctors consider that it's necessary to do arteriography before operation, to do arteriography and embolization. What is this arteriography and embolization? This procedure, for example, we do to stop the nasal bleeding. Next lecture we will discuss nasal bleeding, epistaxis. Also, we can use arteriography and embolization in the last variant of treatment to stop the bleeding. And arteriography, we do incision in the skin and the lower extremities. Insert a catheter and move this catheter till the carotid arteries. After, insert a contrast, and we can see the vessels which supply this tumor. And after that, we do embolization, this internal blockage of the vessels which supply this tumor. After that, blood supply of tumor will stop, and risk of bleeding during operation will decrease. The size of tumor also will decrease. And after that, after embolization, we do operation, surgical removal. Another variant of treatment, another opinion. Some doctors consider no need to do arteriography before operation. No, arteriography with embolization, because arteriography with embolization also have risk. In this situation, we insert the contrast, and after that we insert the embol, we insert the blockator or to close the vessels inside the vessels. And if vessels can change the size a little, the tension of the wall of the vessel can change, and it's possible that this embol will not fix correct and will travel, and if it's travel, it can block another vessel which supply the cranial cavity. It's possible to get serious intracranial complication. We should understand that we walk inside the vessels which supply the cranial cavity. Not some doctors consider no need to do it because high risk of complications. It's better to prepare for the severe bleeding, to prepare everything to stop the bleeding, and even prepare the blood, and even blood of same patient. We can take blood of same patient several days before operation, and during operation we'll do blood transfusion of this blood, and if it's necessary, additional another blood. And how to do operation? Operation, it can be different variants, different approach. And it's depend from the many factors. Million times already today I repeated, that dependent from localization, size, spreading of the tumor. Usually classically, we do it endoscopically through the nose, endoscopically remove the tumor, but it can be big, it can maybe not pass through the nose, maybe combination through the nose and through the mouth. Now this picture, for example, you can see removal of the tumor through the maxillary sinus. Now in this patient, a very big mass of tumor lays localized inside the maxillary sinus. And in this situation, it was more comfortable to remove it through the maxillary sinus, through the, what you can see, removal of anterior wall of maxillary sinus, and remove this tumor. And here you can see CT of patient after this operation, after removal of the tumor, after removal of angiofibroma. What you can see after operation, we get one big cavity. What you can see, this size maxillary sinus. Here, no maxillary sinus, only with this part of this corner present. This wall of maxillary sinus removed. It was broken by tumor. Inferior turbinate here present, here no. Also, it was broken by tumor. Septum, you can see only cartilaginous part present. Bony part, it should be here. It's absent. And asymmetry present because tumor present long time, and tumor press on the walls. Finally, after operation, we can see one big cavity, which include nasal cavity, maxillary sinus, nasopharynx. Very often in this situation, atrophic rhinitis developed because several episodes before we discussed atrophic rhinitis, and one of cause of atrophic rhinitis is post-surgical, and here it's possible to development of post-surgical atrophic rhinitis, but I repeat, this tumor typical for young men. Usually they have very good regenerative possibilities, and usually atrophic rhinitis don't develop, don't reach serious stages, and regeneration of the mucosa usually develops, and finally no atrophic rhinitis. No, also like in angiofibroma, it can be different tumors of nasopharynx. Also, it can be other tumors, other benign and malignant. What very important question about, I didn't finish about biopsy. And what here in this tumor, usually we do biopsy after removal. What we remove this tumor and after that send it for histological examination. Sometime situation present in which maybe atypical development of this tumor. What we examine and we don't see very good vascularization, we don't see, and we don't think about angiofibroma. Well, sometimes diagnosis of angiofibroma we put after biopsy. What we see something, we see tumor in nasopharynx without typical clinical signs of angiofibroma. We do biopsy by forceps with controlled endoscope, remove small piece of the tumor, send it to histological examination and see results angiofibroma. This situation also possible. But I repeat, in today's topic, no diseases which has what very clear classical clinical picture. Different tumors can present in the nasopharynx and malignant or benign, and clinical picture can be different. Clinical picture usually related with obstruction of nasopharynx, like adenoid hyperplasia. Final diagnosis, we can put this only histologically. And treatment, final treatment depend from the stage of the tumor and depend from the final diagnosis. And tumors of oropharynx. What here you can see, for example, the other tumors of nasopharynx. What here you can see in posterior endoscopy, we can see something. Tumor in nasopharynx. What we can see here very clear, we can see picture of nasopharynx, posterior wall of nasal septum, vomer, coana, open manifestation tumor. And what this is, this tumor. Here also what some ulceration, tumor with ulceration also present in the nasopharynx. Tumors of the pharynx. Different tumors can be can develop in the pharynx, but you should remember inside pharynx we have tonsils, the lymphoid tissue, lymphoepithelial tissue, and it can be tumors of the tonsils. For example, here very typical benign tumor, papilloma of the soft palate, usually on the uvula. What so often, not so rare, it's present, and patients see something through the mirror. Maybe patients see presence of this when open the mouth. Patients feel that something not pleasant feeling. Not in this situation. It's enough to remove it by one movement, maybe put one suture, and after that send it for histological examination. But what in other pictures, what in these several pictures, you can see malignant tumor of the tonsils. What even here, what this is tonsil, and here, here it's not malignant. Here, total papillomatosis of one tonsil. Here also what malignant tumor of the tonsil, and what should you remember? Usually, tonsillar tumors is very malignant, and in comparison, tumors of lymphoid tissue, usually it's very, very malignant. And clinical picture again depends from localization, from the size, from the spreading of the tumor. First of all, usually, if we talk about oropharynx, first of all, usually it's a problem with swallowing, unpleasant feeling in the throat, maybe pain. Later, it can be bleeding, and this tumor can spread also to the laryngopharynx and to the larynx and lead to the about tumors of the larynx. We'll talk more detail later. Even it can be a problem with breathing, with respiration. And for diagnosis, also sometimes it's necessary to do CT to see spreading of this tumor. It's necessary to do visual examination. Necessary to do biopsy. No, also, in all tumors, especially malignant tumors, we must do more detailed examination of the patient to find the metastasis in other organs and systems. And treatment depend from the stage of the tumor, presence of evidence of metastasis, if it's malignant tumor. In earlier stage, it's possible to do only tonsillectomy, maybe remove the tonsils. In later, in more later stages, necessary to use radiotherapy, chemotherapy, maybe combinations of surgery with radiotherapy and with chemotherapy. Так, now 10 minutes break, and after break we continue. Let's continue. Tumors of larynx. Like in all other organs, can be divided malignant and benign. What we will talk about several more popular tumors of the larynx. First, this is benign tumors, and this is fibroma. Fibroma, this is tumors which usually localize on the vocal cords, and etiology, this is like all other fibromas, and usually it's localized on the free edge of vocal cord. It can have small size, it can be several millimeters, usually till 1 centimeters and a little more. And symptoms here, when we talk about tumors of ENT organs, first we should remember about function of these organs. What functions of the larynx is phonation, breathing, and protection also. Two visible functions, phonation and inspiration, breathing. And in this disease, breathing will not be affected. Problem with voice present, and patient with laryngeal fibroma, first of all, has hoarseness of the voice. Dysphonia, it can be cough. Also, it can be, if there is very big fibroma, it can be respiratory obstruction, not severe respiratory obstruction, in severe physical activity. Usually no problem with breathing, problem with voice present. First of all, hoarseness of voice. In examination, out here in all these pictures, you can see fibroma of the larynx. Final diagnosis, of course, we can put only after histological examination. I know, and I tell you, this is all in all these pictures, patients with fibroma of the larynx. What this is one patient, first line, picture number 1. This is during larynx during phonation. Picture number 2, larynx during inspiration. And on both of them, you can see what is fibroma on the free edge, on the internal surface of the vocal cords. What this is vocal cords, what vocal cords, and what here, on one of them, what present tumor. And due to this tumor, vocal cords, what one vocal cord cannot attach to another completely. There's glottis placed between vocal cords. Glottis cannot be closed completely. And because not complete closure of the glottis, what here present, cleft present, not correct voice, hoarseness of the voice. This tumor, usually several millimeters, it can be on the pedicle or on white base, it can be grayish color or pink color. And main problem, I repeat, this is not complete closure of the glottis. Final diagnosis, we can put only after histological examination, but for histological examination, we must do biopsy. But here, in this case, biopsy, manipulation for biopsy is equal for manipulation for removal of the tumor. In this case, first, we will do operation, removal of the tumor. After that, tumor which we removed, we will send for histological examination. How to do this manipulation? Several variants. Here we can do several variants of examination of the larynx and several variants of manipulation. Here you can see indirect laryngoscopy. In indirect laryngoscopy, by left hand we pull out the tongue of the patient, by right hand insert the mirror. Here you can see it can be mirror or 90-degree hard endoscope. For manipulation, patient take the tongue by himself or assistant take the tongue. By left hand we take the mirror or endoscope. By right hand we take this is spatial forceps. And with control of mirror, we insert this forceps directly into the larynx and remove this fibroma. No, we must be careful. Really, it's very difficult manipulation because this part of the we see through the mirror, and when we want to move in the mirror one side, but we can see it move in the another side. No, it's very difficult to do for not experienced doctors. Another variant for manipulations and for examination and for manipulations in the larynx. This is flexible scopy. We insert it directly into the larynx. No, it can have this laryngoscope can have inside the canal, and inside this canal we can insert special forceps. No, but this forceps is very, very small, no, and also not so easy. No, and finally we can do direct laryngoscopy. Direct laryngoscopy, patient with general anesthesia. What here you can see, we insert laryngoscope, fix it on the chest of the patient, and no, additionally we can use microscope, or additionally possible to use endoscope inserted through this laryngoscope, hard, rigid scope, and what by special forceps we can remove this tumor, remove this fibroma. But we must be careful, because if we remove so much, we can remove the fibroma together with mucosa of vocal cord, and in this situation, we can get deformation of vocal cord, and patient will have hoarseness of the voice after operation, but already due to another cause. Next tumor. This is laryngeal papillomas, laryngeal papillomatosis. This is tumor papillomas. This is tumor due to virus, human papillomatosis virus, and it's affect the larynx, and in comparison with fibroma, it has it's grow more quickly, and it has very big size, and it's has appearance like raspberry, and what like too many small papillomas, very small maybe, and it's usually localized on the vocal cords also, but can spread outside from the vocal cord and can spread to the opposite side, to another vocal cord. And it's typical for, it can develop in different ages. What it can develop in children, or vice versa. It can start develop and finish develop in children and finish development in puberty period. Or another variant, it can start the development in puberty period. It's related with hormonal level in the patient. Symptoms here also hoarseness of the voice, cough, and what here respiratory obstruction can develop. No, respiratory obstruction develop not suddenly. It's develop long time, after a long time, and usually patient feel respiratory obstruction first not severe, after it can increase. In examination we can see what like here I described already, that it has possible to say like raspberry, and what origin on one vocal cord, and after that can spread to the different directions. And final diagnosis, again, we can put only after histological examination. For treatment, because it's this tumor has viral etiology, here we use combined treatment. Main treatment is surgery, surgical removal, but usually, very often, we get recurrence of this tumor. But to prevent possible recurrence, or to decrease the speed of development of this tumor, we prescribe the immunotherapy and antiviral treatment. Surgery, like in previous case, like in case of laryngeal fibroma, but usually we do what? Direct laryngoscopy. Usually we do direct laryngoscopy. Usually the typical development of this tumor We see the patient of this tumor, of these tumors, but we don't do immediately operation because we know that we remove it and it will grow again. We wait, and if we see that risk of respiratory obstruction present, what we do? Surgery. Remove the tumor, use immunotherapy, use antiviral therapy, and finally, no, not finally. After that, this patient has constant examination. This patient should be examined the ENT doctor periodically. Usually this patient live with contact with ENT doctor. And we can see after a period of time what it's again begin to grow. But it don't develop quickly, but possible. That's possible that it's developed. And what sometime we remove this tumor several times for one patient. No, but I told already it has relation with hormonal period, and sometimes the situation possible that, for example, in childhood it's present in childhood, but after puberty period, the development of this tumor stop, or maybe after puberty period it's developed. After several years, development of this tumor stop. Malignant tumors of the larynx. First of all, carcinoma, laryngeal carcinoma. From all tumors of the ENT organs, more often tumors of the larynx present. And from all tumors of ENT organs, more often we have patients with laryngeal carcinoma. First place in ENT oncology, this is carcinoma of the larynx. No, etiology. We will not discuss. We talk already about etiology. Not here. If we talk about smoking is very important here. Yeah, because larynx is like possible to say one of first barrier on the what this air which smokers inspire. And but it's not obligatory. Sometimes laryngeal carcinoma present in patients who never smoke. But here it's clear that smoking important for development of the tumors of the larynx, especially for laryngeal carcinoma. First, let's talk about about TNM classification. TNM classification of the laryngeal carcinoma. Here it's very important because we have too many patients with laryngeal carcinoma. TNM, T, this is tumor, N, nodes, regional lymph nodes, M, metastasis. T, this is, it can be T1, T2, T3, T4. T1, tumors affect one anatomical site of the larynx. It means one anatomical element. It can be vocal cord, vestibular fold, epiglottis, ventricles, arytenoid cartilage, like this. T2, tumor affect one anatomical region. We have three regions in the larynx: supraglottis, glottis, and subglottis. T3, tumors spread outside one anatomical region, but don't spread outside the larynx. And T4, tumors spread outside the larynx and affect the neighbor tissues, cartilages, ligaments, muscles. N, lymph nodes. It can be N0, no lymph nodes. N1, mobile lymph node, same site. N2, mobile lymph nodes, opposite side or both sides, bilateral. And N3, fixed node, not important which side. And M, metastasis. M0 absent and M1 present. Symptoms. When we discuss the fibroma, we talk already about functions of the organ, functions of the larynx. And here also, first of all, problems with voice develop. First of all, patient has Usually first sign of this tumor. This is hoarseness of the voice. Hoarseness of the voice, dysphonia. Also, it can be cough. Also, it can be global sensation in the throat. Also, it can be feeling of cleaning of the throat, feeling of foreign body, pain can present. Also, it can be later it can be bleeding. Later, it can be dyspnea, and also dysphagia because it can spread bleeding. It can be that hemoptysis after that serious bleeding. Lymph nodes, patient by himself or herself can palpate lymph nodes, but more typical this tumor for men. More often laryngeal fibroma present in men. In examination, we can see different pictures. What in all these pictures, we can see laryngeal carcinoma. What here you can see it's not like possible to see. It look like benign tumor on one vocal cord. What here total affection of vocal cord. Here you can see already more serious pathological process in other pictures. Histologically, also it can be different tumors. Laryngeal carcinoma histologically can be different, and it's important for the treatment also. Later we'll talk about treatment. Additional examination. First of all, here we should do histological examination. Take the biopsy, and usually we have situation when patient come to the doctor first time with hoarseness of the voice. We look at the larynx, and we see what we think about. We suggest the tumor, suspect the tumor of the carcinoma of the larynx. In this situation, we must do biopsy. Also, we must examine lymph nodes. Examine the regional lymph nodes, do ultrasound of lymph nodes of the neck, and if it's necessary, do puncture and aspiration and biopsy, aspirative biopsy of lymph nodes. Biopsy of the carcinoma, we will be back now. What here usually we do it like during indirect laryngoscopy. By this forceps, we take small piece of tumor and send it for histological examination. Maybe during indirect laryngoscopy some problems present, we can do it with direct laryngoscopy. Put the diagnosis, and after that we take the decision about treatment, which variants possible. It can be if no metastasis, no lymph nodes, it can be surgery. About surgery we will talk after several minutes. Or sometimes surgery already impossible to do. We can do radiotherapy only. Is chemotherapy not effective for these tumors? Only radiotherapy. But not all tumors sensitive for not all carcinomas, laryngeal carcinomas sensitive for radiotherapy. It's important to know the histological type of the carcinoma. One more variant. When patient has respiratory obstruction. Sometimes patient admit to the hospital with severe respiratory obstruction. Here two variants possible. One variant, patient never get examination and patient didn't know about laryngeal carcinoma. Another variant, patient already know about laryngeal carcinoma. First, for example, patient didn't know about carcinoma. Patient admit to the hospital with serious respiratory obstruction. In this situation, what can we do? What should we do? In this situation, we do tracheostomy. We do tracheostomy. If we don't know, if patient didn't know about carcinoma, if no diagnosis of carcinoma, after tracheostomy, we give for patient 2-3 days for adaptation for tracheostomic tube and for adaptation to the breathing. We take the biopsy. No, and after that, we'll get the results of biopsy. No, unfortunately, usually, no, we cannot do anything more. No, because if patient has respiratory obstruction, it means that it's already a very serious stage, and usually it's last stages. No, and if patient know about tumor, if diagnosis is present already, or sometimes patient admit to the hospital with respiratory obstruction, yeah, we do tracheostomy, and patient has documents, patient already know about laryngeal carcinoma. Also, our possibilities finished here. We cannot do anything more. We can prescribe for the patient if it was not prescribed before radiotherapy, if this type of tumor sensitive for radiotherapy. That's all. Tracheostomy only will prolong the life of the patient for period of time. And surgery, if it's possible to do surgery, which types of operations can we do for this disease? For patient with laryngeal carcinoma. About tracheostomy, one operation tracheostomy. No, tracheostomy is not for treatment of tumor. That tracheostomy is to save the life of the patient. For treatment of the tumor, first, microsurgical decortication or removal of this tumor during endoscopic manipulation or direct laryngoscopy. Another variant, chordectomy, removal of one vocal cord. No, usually, more often, origin of the carcinoma in the larynx is vocal cord, or removal of one vocal cord. It's also usually endolaryngeal manipulation. Endolaryngeal, it means through the mouth, through the opening of larynx. No, and the next variant is more aggressive operation, partial laryngectomy, usually hemi-laryngectomy, vertical or horizontal. It's operation through the neck, incision of the neck, skin, incision of laryngeal cartilage, and removal usually half of larynx, and formation of new way for breathing. And last operation, total laryngectomy. In this operation, we remove the larynx completely. Several words, prognosis in all these cases, prognosis depend from the many factors. First of all, from the stage of the tumor. In case of if we do hemilaryngectomy or total laryngectomy, prognosis usually not very good. Так, infectious granulomas of ENT organs. First, scleroma. Scleroma is infectious disease due to Klebsiella rhinoscleromatosis. And this Klebsiella affects the mucosa of the upper respiratory tract. And on the place which affected by this Klebsiella, patient has development of the infiltrate, developed a tumor-like mass. And this mass can increase the size, and it can look like tumor. And the problem here, due to presence of this mass and due to size of this mass. It can localize in different places. It can localize in the nose. It can localize in the nasopharynx. It can localize in the larynx. If it's localized on the nose, usually patient has symptoms of the problems with nose. It can be nasal obstruction, nasal secretion. It can be development of sinusitis due to blockage of the openings of the paranasal sinuses. But more interesting for us and more dangerous is scleroma of the larynx. Scleroma of the larynx, when it's present in the larynx, it's always localized in the subglottic part. It affects mucosa under the vocal cord, subglottic area. And the clinical picture here, like in other diseases of the larynx, we think about voice and breathing. First, usually patient has problem with voice, hoarseness of the voice, dysphonia. It can develop long time, and finally it can lead for development of respiratory obstruction. And finally, patient can have respiratory obstruction because this infiltrate increase in size, increase. It can be concentrated. No, for example, no, just I will draw. Out here you can see the larynx. What larynx? It's what here beginning of trachea. What this is vocal cords. And under the vocal cords, it can be development of this infiltrate, not like this. Well, first, it can be small. After that, it can increase in size, increase. Space here decrease. No, finally, it can lead to the serious narrowing. And this lumen is not enough for normal breathing. And it finally, it leads to the respiratory obstruction. No, respiratory obstruction don't develop after 1-2 days, and usually don't develop after 1-2 years, and even more. In Kursk region, we have several patients with scleroma, and some of them already treated in our hospital 20-30 years. And how to treat? We prescribe courses of antibiotics and steroids. No, but because this is Klebsiella here, no adequate treatment of this microorganism, no complete treatment of this disease. We can only decrease the speed of development of this infiltrate. No, and if respiratory problem is present, in this situation, if patient has problem with breathing, it was different attempts what to do. It was attempts of compression, so it's special balloon, what like for the treatment of atherosclerosis, sometimes used. What insert the special balloon in this space, and after that, what insert the air, and this balloon will increase in size and press is infiltrate. It give results, but for short period of the time. It was attempts of surgical removal. Surgical removal, so remove surgically these infiltrates. Also, it gives results, but also for short period of the time. And after that, it's begin to grow more quickly than before removal. No, unfortunately, what now no effective treatment and only one manipulation which we can do. This is tracheostomy. Sometime, if no other variants, we do tracheostomy. Here, only one question. Finally, patient will live without tracheostomy or with tracheostomic tube. I repeat already what I told already. In our department, we have too many patients several patients with scleroma. Some of them already about 30 years lives without tracheostomic tube. Periodically, courses of conservative treatment. But some patient has tracheostomic tube. Unfortunately, no other variant. Next disease, tuberculosis. Tuberculosis of ENT organs, and tuberculosis, first of all, more often present in the larynx, laryngeal tuberculosis, and also tuberculosis can affect the nose, pharynx, but not often. Usually it affects the larynx, and it's always secondary after pulmonary tuberculosis, after primary pulmonary tuberculosis. And symptoms include hoarseness of the voice, cough. Later it can be respiratory obstruction. Symptoms, what you can see in different diseases of the larynx, symptoms can be same. But here can be symptoms of chronic laryngitis. And sometimes we examine larynx and we don't see something interesting. It can be also picture like in laryngitis. In this situation, we must be attentive. And what is typical for tuberculosis? It can be formation of the ulceration on the vocal cords, It can be formation of the ulceration between the arytenoid cartilages in interarytenoid space. No, vocal cords. No, and more typical sign, this is monocarditis. Monocarditis, inflammation on one vocal cord, not like here on this picture you can see. Monocarditis, inflammation of one vocal cord. If you see patient with inflammation of one vocal cord, first of all, you must think about tuberculosis. Not obligatory, not obligatory. It can be what is the hour. Sometimes patient don't know about presence of pulmonary tuberculosis, and patient don't know. Patient come to the patient has problem with shortness of voice and cough. We examine, we see signs of laryngitis. What ENT doctor see laryngitis, and we treat laryngitis. Treat. No, slight effect present, but not complete effect. What in this situation we must think and remember about tuberculosis. Sometimes we ENT doctors we are first who put diagnosis of tuberculosis for the patient. We think about laryngeal tuberculosis. We do examinations for tuberculosis. We put the diagnosis of tuberculosis, and we give for patient chance to get normal treatment with normal time. And one of signs of tuberculosis, this is one vocal cord inflammation of one vocal cord. If you see the patient with signs of laryngitis, you see inflammation of one vocal cord, first of all, it's necessary to think about tuberculosis, and it's necessary to prescribe for patient special examination for tuberculosis. And usually, if we do this examination, we see results, tuberculosis, and we send this patient for special hospital, TB, for specific treatment of this disease. And syphilis of ENT organs, also several words about syphilis. Syphilis also can affect different organs, different ENT organs. And about syphilis, you should understand that syphilis has several stages, and what in the syphilis we have primary syphilis, secondary syphilis, and third period of syphilis. And in different organs of syphilis, it can be, and in different organs, ENT organs, it can be different stage of syphilis. For example, if we talk about pharynx, in pharynx it can be different stages of syphilis. In pharynx it can be primary syphilis, because pharynx it can be source of gates for infection to the organism, and it can be like formation of ulceration in the pharynx, for example. And also second period, more common. Second period of the syphilis more common in the pharynx, and third period also can present. What should you remember again? What we talked about tuberculosis several minutes before. That sometimes its clinical picture is not clear. It's always not clear. We examine the larynx and we see signs of laryngitis, or tuberculosis can look like carcinoma, or like other disease. And it's important to do special examination, maybe even to do biopsy. What also it's important if we examine the pharynx. What we have situation, we examine the pharynx, unclear situation, some ulceration present, some cavern present, inflammation present, but not clear, and it's not acute tonsillitis. Possible to think about acute tonsillitis, but not acute tonsillitis. Possible to think about some chronic tonsillitis, but not chronic tonsillitis. But also we must be attentive. We must be attentive. No, in the pharynx it can be many different types of infection. In the pharynx it can be diphtheria, it can be scarlet fever. We discussed several lectures before classification of tonsillitis. And tonsillitis it can be different. I repeat, diphtheria, infectious mononucleosis, No, syphilis usually signs not like acute tonsillitis. Usually it's like chronic tonsillitis. No, and what should you remember? When you examine the pharynx, and also what no need to forget about all types of infection, and about syphilis also, and it's necessary to prescribe correct examination, and sometime also like for tuberculosis, where first doctor ENT who put this diagnosis tuberculosis, sometime also patient don't know about syphilis. What we examine the pharynx, we prescribe examination for syphilis, and we can see what yes, this is syphilis, and patient will be hospitalized to special hospital, dermatological hospital, and get special treatment. No, and syphilis of the nose, several words, more popular syphilis of the nose. Usually it's gumma, field stage, and usually gumma localized on the nasal septum, and also can localize on lateral wall of the nasal cavity, but usually on the nasal septum. First patient has nasal obstruction, maybe periodical bleeding. Later it can be formation of the crust, ulceration. Finally, development of necrosis of this gumma, and with destruction of the skeleton of the nasal septum. But skeleton of the nasal septum, if you remember, this is also part of the external nose. And in this situation, it can be deformation of external nose. It was popular diseases in previous century when it was no antibiotics, and now it's not so often present, and now it's possible we can put the diagnosis in earlier stages, and now we can prescribe the treatment. But usually syphilis now don't reach the stages when gumma of the nose develop, and finally deformation of external nose. But several centuries before, it was typical situation. Так, значит, now I will open the chat. Так, now students who present here, write your names and group in the chat, and так, сейчас I will open. Так, please write your name and group in chat, and after that you can leave. Значит, our lecture finished. Goodbye. Thank you for your attention.